Hi there. Let's review this long case study on cancer. Just to provide a bit of background, with cancer, the majority of cases, about 70%, 76%, are diagnosed in individuals who are over 55 years of age. However, it does occur with people in all ages, and it's estimated that 1.3 million persons were diagnosed with cancer in 2006. In that same year, half a million Americans died as a result of cancer. Cancer incidence overall is higher in men than in women, and it is the second most common cause of death in the United States, with heart disease being the most common. However, in people that are less than 85 years of age, cancer is the leading cause of death. More than 10 million Americans are alive today who have a history of cancer. The 5 year survival rate is now 65%, and that's an 11% gain over the last 20 years. So that's a little bit of information. Oops, what's this? Go away. Okay, so let's talk about Mr. Anderson. Mr. Anderson is a 62-year-old male who is retired from a high school, being a high school math teacher, and he lives on a small farm with his wife. He has two adult children and remains active working on his farm and part-time doing roofing and small construction projects. He was a two-pack a day smoker for over 29 years, but quit 20 years ago in 1990. Well, that would be more than 20. That would be 26 years ago. 27 years ago. He has been healthy with no medical concerns until this past month, and he has had an increased shortness of breath and increased fatigue. So, if we need to calculate his pack years, how would we go about doing that? Well, 29 years times two packs, that would equal 58 pack years. So he has a 58 pack year smoking history. The second question is differentiate and describe the three phases of cancer development. Well, the first phase is initiation, and that is a mutation in the cell's genetic structure resulting from an inherited mutation or an error that occurs in the DNA replication, or following exposure to a chemical, radiation, viral agent, some type of carcinogen. These altered cells have the potential for developing into a clone, or a group of identical cells, of neoplastic cells. So the initiation is irreversible. We can't do anything about this. But not all altered cells go on to establish a tumor, and many undergo apoptosis. Carcinogens can be chemical, radiation, or viral in nature. Some are genetic anomalies increased by susceptibility of individuals to certain cancers. Some characteristics of carcinogens are that their effect in the stage of initiation are usually irreversible and additive. Chemicals, um, rare, not many that we are exposed to. Radiation, the ionizing in radiation causes damage to the DNA strands, and that increases cancer, such as during the bombing in Hiroshima and Nagasaki. Also, X-ray technicians have a higher exposure to these to radiation. And then an example of viral is human papillomavirus (HPV) that causes cervical cancer. Promotion is characterized by reversible proliferation of the altered cells, so that the key word here is reversible. Consequently, with an increase in an altered cell production, the likelihood of additional mutations is increased. An important distinction between initiation and promotion is that the activity of the promoters is reversible. This is a key component in cancer prevention. Promoting factors include such agents as dietary fat, obesity, cigarette smoking, alcohol consumption. Changing a person's lifestyle to modify these risk factors can reduce the chance of cancer development. Approximately half of cancer related deaths in the United States are related to tobacco use, unhealthy diet, physical inactivity, and obesity. Several promoting agents exert activity against specific type of body tissues or organs. Therefore, these agents tend to promote specific kinds of cancer. For example, cigarette smoking is a promoting agent in bronchogenic carcinoma, and in conjunction with alcohol intake, it promotes esophageal and bladder cancers. Some carcinogens, complete carcinogens, are capable of both initiating and promoting the development of cancer. Cigarette smoke is an example of a complete carcinogen and capable of initiating and promoting cancer. Progression is the increased growth rate of the tumor, increases invasiveness and spread of the cancer to distant sites, which is called metastasis. Certain cancers have an affinity for a particular tissue or organ as a site of metastasis. For example, colon cancer spreads to the liver. Other cancers are unpredictable in their pattern of metastases, such as melanoma. You can't really predict that. And the most frequent sites of metastases are the lungs, brain, bone, and liver, and adrenal glands. So our question, oops, that's not a question. Is differentiate, oh, probably. Let's go on to the next one. This is the question. How does cigarette smoking specifically influence the development of lung cancer? Well, cigarette smoking is the most important risk factor in the development of lung cancer. Smoking is responsible for approximately 80% to 90% of all lung cancers. Tobacco smoke contains 60 carcinogens in addition to substances, carbon monoxide, nicotine, and these interfere with normal cell development. Cigarette smoking is a lower airway irritant and causes a change in the bronchial epithelium, which usually returns to normal when smoking is discontinued. The risk of lung cancer is gradually lowered when smoking ceases and continues to decline with time. 10 years following cessation of smoking, lung cancer mortality risk is decreased by 30 to 50%. So it's well worthwhile quitting so you decrease your mortality. The questions, pardon me, describe the biological process or the role of the immune system related to cancer development, and describe ways in which malignant tumors spread or metastasize. This is an excellent video describing this.
Spread of tumors to distant locations is of great importance in cancer. About 90% of the deaths due to cancer involve tumors that have spread around the body. The movement of tumor cells to other parts of the body is known as metastasis. Metastasis is a complex process during which cancer cells break off of the original or primary tumor and move through the body to form tumors at new locations. From the point of view of a cancer cell, this is a dangerous and often unsuccessful process. A trip through the body is full of hazards that cause the death of most cells that begin the journey, even tough cancer cells. To begin the process, individual cells must break away from the tumor and invade nearby vessels. The cells crawl along the surface of other cells and the fibrous, stringy structure surrounding them and then force their way in. Shown here is the invasion of the blood supply. Once inside a blood vessel, the cancer cells may perish from a variety of causes. Some cells die simply because they are unable to survive floating around in the bloodstream. Others may become damaged and die when they squeeze through tight spaces or bump into the walls of the blood vessels. Still, other migrating cells may be recognized and destroyed by cells of the immune system. How and where the migrating cells stop is different for different cancer types. Once the tumor cells are no longer moving, they can begin the process of forming a new tumor by leaving the blood vessel and beginning to reproduce in the new location. This does not always occur, and cells that have made it this far may still die or fail to divide. If the new environment is suitable, the newly arrived cell will begin to grow and a new tumor will develop.
So Mr. Anderson was diagnosed with small cell lung cancer 17 days prior to being seen in the emergency department where you are working. A CT scan confirmed that he has tumors that have metastasized from his lungs to his liver to his right femur as well as his left chest wall. So describe the process by which neoplastic growths cause symptoms. Tumor cells that do survive the process of metastases must create an environment in the distant organ site that is conducive to their growth and development. This growth and development is facilitated by the ability of the tumor cells to invade cells of the immune system and to produce a vascular supply within the metastatic site, similar to that developed in the primary site. Vascularization is critical to the supply of nutrients, to the metastatic tumor, and to the removal of waste products. Vascularization of the metastatic cells is also facilitated by tumor angiogenesis, factors produced by the cancer cells. Ultimately, caused by pressure on the body as the tumor is able to grow as it established in the needed blood supply at the distant site. So it causes pressure as it gets bigger. Define the terms of grading and staging. Well, that is gone over quite extensively in the textbook as well as in the long cancer lecture. So I'm going to just skip over this. This is something you just sort of have to figure out and apply. So what stage of progression does this represent for Mr. Anderson? Where's he at right now? Well, he has metastasized, so he's at a stage 4. I wonder why that keeps popping up on us. Sorry. What is the significance of the staging? Well, the staging determines the extent of the malignant spread, and when distant metastases is present, it consistently is an ominous sign that increases the likelihood of death by cancer. Initially, he was told he only had 4 months to live, and he found a physician who was willing to try experimental chemo regime on him that could prolong his survival. So what is the prevalence, incidence, survival, and mortality rates of lung cancer in the U.S.? The leading cause of cancer-related deaths is 28%, and over 117,000 each year. The leading cause of cancer death in men and women, 600% increase of deaths from lung cancers from 1950 to present, a 600% increase between over these 67 years, and that's totally because of cigarette smoking. This 5-year survival rate is only 15% in lung cancer, and in the United States 20 years ago 203,000 people were diagnosed with lung cancer, and 158,000 died from it. So approximately 3/4 of the individuals die from it. So he first received his first chemo regime, gemcitabine and carboplatin and inaparib, which was the experimental one day prior to this emergency room admission, and he's developed persistent nausea and vomiting and has not been able to keep anything down. So now he's in the emergency department seeing you. So what are the physiological effects of chemotherapy to healthy body cells? Well, the actual mechanism is that it's cytotoxic. There are only 3 ways of getting rid of cancer. You either poison it with a chemotherapy, you either burn it with radiation, or you cut it out with surgery. So the cytotoxic is categorized by their influence on the relationship to the cell cycle. Either the cell cycle or the non-specific or the cell cycle specific. It's in combination of one of these or each of these increases the effectiveness. There is some selectivity, and it damages the cell DNA, causing cell death when it tries to divide and cell division. Rapidly dividing cells are more sensitive to chemo. So what's rapidly dividing? things that grow quickly: skin, hair, intestinal tissue, sperm, blood forming cells. These are cells that we produce quickly, so they are affected by chemotherapy. So therefore we see the skin loss, or the, pardon me, hair loss. We see skin breakdown. The mucosa, which is in our alimentary tract, breaks down. So we have mouth sores, GI upset. Chemotherapy is spermatogenic, so it kills off the sperms, which are rapidly producing cells as well. And as well, it affects our blood cells. So, how is chemotherapy administered and through what type of vascular device is needed? So, intravenous through a central line. Usually, we would use a PICC cell or a PICC line, a PICC line, pardon me, or an implanted port. This is some examples of some implanted ports down here. And this is the Huber needle that we use to access those implanted. Our nursing responsibilities are for the PICC, we're going to assess for signs of phlebitis, redness, pain, edema along the track of the catheter, look for signs of infection. And then for the port itself, we have to flush it per hospital protocol with heparin, usually every 12 hours to ensure patency. But I want you to remember that it's per hospital policy as well as manufacturer recommendations. We are also looking at the sites for signs and symptoms of infection. Most common side effects of chemotherapy: bone marrow suppression. Most common effect, pancytopenia, which means decrease in all blood cells, not just white, all cells. Pano, all blood cells. So we want, our nursing intervention would be neutropenic precautions, stringent hand washing. Fatigue, 70 to 100% experience fatigue, and this is the most stressful. They are just dog tired all the time. So as nurses, we want to promote rest, good nutrition, and sleep. The GI effects: intestinal mucosa is sensitive to the chemotherapy, so we use why does this keep doing this to me? Stop and don't do that. Sorry. GI effects: intestinal mucosa is sensitive to chemotherapy. So for the nausea and vomiting, we're going to give them antiemetics. We're pretty good at that now. Zofran's an amazing drug. Diarrhea, that's also a problem. Mucocystis, oral ulcers, we're going to give them good oral care. And obviously good perineal care if they have diarrhea. Skin reaction, rapidly proliferates because our skin turns over so quickly. It is susceptible to chemo. We see redness of the skin. To hair loss is the most common. The degree and sensitivity depends on the type of dose of chemo agent and is usually reversible. The respiratory effects: it can cause damage that can be irreversible and progressive, non-cardiac pulmonary edema due to capillary leakage and inflammatory response. Cardiovascularly, chemotherapy can cause heart failure and cardiomyopathy, so that is not reversible. We also will see with these individuals that they may end up having some, because of the myopathy, they end up with some rhythm problems and end up with pacemakers and implantable defibrillators. Reproductively, it can cause early menopause in women and sterility in men. Describe the nursing management of the patient receiving chemotherapy before, during, and afterwards. Well, nursing care is directed directly towards assessing and manage the most common side effects of chemotherapy. So we're going to, if it burns, we're going to assess the site and turn it off. We're hoping for a central line, and we're going to look at all the side effects of the chemotherapy agents. So what is the dosage, mechanism of action, nursing responsibilities, and most common side effects of the following antiemetics? So we have Zofran here, Compazine, Phenergan, and Ativan. I don't need to read through those for you. I'm sure you can read them on your own. So, in addition to Mr. Anderson's nausea and vomiting, he begins to feel increased weakness, fever, chills in the afternoon at home. Because of a fever that has lasted past 6 hours, he was as high as 105. He's come to the emergency department for further evaluation and treatment. He took 1,000 milligrams of Tylenol and don't show me that message again. Finally read it. Okay. Um, he took 1,000 milligrams of Tylenol and 600 milligrams of ibuprofen before he came to the emergency department in this small community hospital where close to where he lives, where you're working. So, what is the dosage, mechanism of action, nursing responsibilities, and most common side effects of the following antipyretics? So, we have acetaminophen, ibuprofen, and we can read through those. So, upon his admission, we see that he has a temp of 104.1. His SATs are 95% on room air. He is not in acute distress and he has no complaints of pain. He does appear weak. His lips are dry and his tongue and oral mucosa are tacky dry. His breath sounds are clear. Heart sounds are S1, S2 with a soft abdomen, non tender with active bowel sounds. And his skin is dry and hot. So, what is your primary concern right now? I am concerned about his fever. He is likely going to be septic and he's also dehydrated. So, what's causing that? He's immunosuppressed secondary to the chemo that has dramatically lowered those WBCs that are being produced in his bone marrow. Is there any more nursing assessment you need? Yes, I want to know what his heart rate is. I didn't know what that is. If it's tachycardia, that can be explained by fever and needs to be known, not able to assess early sepsis unless the fever and if it comes back to normal and unless the fever comes back to normal and he remains tachycardic. So his blood pressure we must be assessed. And it's not influenced by fever. So we must have a look at that. And if it's low, possibly dehydration because he is showing us signs of that. So our nursing diagnosis would be risk for infection and fluid volume deficit. What nursing interventions based on this concern? Think about it. Use your ABCs when you think about this. B, consider nasal cannula for breathing due to concerns for sepsis and tissue perfusion. C, I'm going to establish an IV. I want to administer IV fluids. What type do I want to give? I'm going to probably start with a normal saline and maybe move to a D5. We're going to assess his blood pressure, heart rate, temperature, respiratory rate very closely for at least 15 to 30 minutes, and we'll want to facilitate his labs, especially the blood cultures. And why is that? Well, we want to identify what's going on, and before we do any treatment, we want to get that culture out so we can identify what if there's a bacteria that we can blame. So, worst possible complication is sepsis, which would lead to septic shock. So, the physician has seen the patient. He's ordered a CBC, BNP, and serum lactate, urinalysis, chest x-ray. What else? Blood cultures times 2. And then once they're drawn, we're going to administer Primaxine and vancomycin. So we are supposed to be looking at accurately interpreting the results of his CBC and differential. So his vital signs now are 98.9, so he's come down. Heart rate's 82, respiratory rate is 20, blood pressure 138 over 88, and satting at 98% on 2 liters. Okay, so his WBC is 29.2. So he has an aggressive response to the body to a fight an infection is going on. I see his neutrophils are 88%, and that will elevate in 6 to 12 hours after an insult. His bands are 0, and that means he's in early sepsis, so there's no bands been produced yet. What is the Labs. What labs are normal that are relevant and must be assessed due to their relevance to this patient? Um, let's look. His creatinine reflects his renal function and his lactate degree of anaerobic metabolism if severe sepsis, and those are not affected at this moment. Because because he had his chemotherapy at an outpatient facility and will need follow up when he is transferred to the emergency department at this time. Upon reviewing the patient from the paramedics receiving him, your assessment reveals that he is weak, pale, and despite receiving 2 liters of nasal cannula at the outpatient facility, his lips are oral and his membranes are dry. He has crackles in his bases and his vital signs are 101, 88 respiratory rate, 22 blood pressure. Oh, he sure jumped around, didn't he? Now he's 88 over 52 and 2 liters per nasal cannula. What is my primary concern? He's still febrile and is he infectious? Does he have an inflammatory response going on? He's hypotensive. He was given 2 liters of fluid resuscitation. He didn't respond to it, and diagnostic criteria for severe sepsis that can quickly move to septic shock. So we're worried about that. He remains clinically dehydrated. What is a nursing diagnosis statement? When we are looking at our ABCs again, this is now into C. He has ineffective tissue perfusion manifested by a decreased blood pressure, and he also has fluid volume deficit. So if we are to look at our nursing interventions again, we need to make sure that he has some good IVs in place so we can give him a fluid resus, and we're going to ask the physician for another liter of fluid to put on board. So the physician comes in and orders that third liter of normal saline to be given and prepares to admit him to the floor. 30 minutes later, he reports that his metastatic pain on his left side is increasing. He appears uncomfortable and describes his pain as the same as the pain he has at home. And it's been 8 hours since he has taken his OxyContin 5 milligrams PO, and he usually takes it every 3 hours for the last 2 weeks to control his metastatic pain. So, what is your primary concern right now? Well, right now we need to control his pain. But are those narcotics going to have an influence on his blood pressure? We're not going to withhold the drug. We're going to give it to him. So the patient's diagnostic statement is acute pain related to compression of the tumor, as evidenced by left-sided pain increasing, that kind of thing. So what it will be your basic nursing intervention based on this concern? I would either give PO or IV pain medications at this point in time, consult with a physician, and get an order. So why do we use OxyContin? It's one of the strongest opioid narcotics we have, and it is a Schedule II. It binds, oh, we can read through this, you all will know, but let's talk about how long it takes to peak. About 60 to 90 minutes, and it has a 3 to 6 hour duration. So it takes about 15 minutes for it to start working, peaks at 60 to 90, and this guy's needing it every 3 hours. So why is OxyContin a better choice than Percocet for this guy? What do you think? Well, I think because he has liver mets. His liver is unable to clear the acetaminophen as effectively and will compound his underlying liver problems. So therefore, we're using the OxyContin. So his third liter of normal saline has just been completed, and there's no other changes, and his repeat vitals are here. Pardon me. So I'm satisfied with those vitals, and What repeat assessment are you going to in the nursing process are you satisfied with? Well, his temp is down, his blood pressure is elevated, his SATs are going up, and he's clinically stable. So we're going to go ahead and transfer him over to the oncology floor. So you can think about what your S bar would be at that time. And that completes this case study.